Hey everyone, Assalamu alaikum and welcome to another episode of ECREM Talks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I'm your host, Anzal Rehman, and today we're going to be diving into some specific concepts surrounding resuscitation during cardiac arrest, in an episode entitled Cardiac Arrest, Can We Do Better? The history of resuscitation dates as far back as the 18th century, where it initially focused on the airways, using mouth-to-mouth breaths to stimulate respirations in victims of drowning, and later on, sudden death. Over time, the use of electricity was found to reinstate heartbeats in collapsed individuals. Compressing the chest became a mainstay in revival techniques, and ultimately, the 20th century saw the formation of the American Heart Society, or the American Heart Association, the AHA, paving the way for standardized methods in cardiopulmonary resuscitation and the inevitable establishment of the Advanced Cardiac Life Support, or the ACLS, in the 1970s. Since then, major leaps and bounds have been made through institutions such as the International Committee on Resuscitation, or ILCOR, to bring us the most efficient techniques and algorithms to manage patients with cardiac arrest. Suffice it to say, the approach to resuscitation has undergone considerable refinement, with significant improvements made in the last few decades alone. Despite intensive research and updated techniques, however, approximately 9 out of 10 patients with cardiac arrest do not survive to hospital discharge, making this one of the most, if not, the worst, feared phenomenon within emergency medicine. So on this episode, we will be discussing certain aspects of cardiac arrest care that possess a certain nuance and potential promise within the realm of resuscitative care, showcasing a potential for future developments and improved techniques to manage patients peri-arrest. We would like to remind our audience that none of the topics discussed on here are to be considered as official recommendations to change current standard of care in any case, shape, or form in cardiac arrest. Rather, we will attempt to dive into interesting ideas and discuss what areas we believe could hold some exciting promise and could lead to innovative techniques in the future. Joining me today is Dr. Laila Hussein, an emergency medicine specialist from the Sheikh Shakhbout Medical City in Abu Dhabi. Laila is an MBBS graduate from the University of Jordan and has completed her residency training in emergency medicine at Rashid Hospital in Dubai. She holds an Arab board and European board in emergency medicine. Laila has a special interest in emergency medicine ultrasound and has obtained a master's degree in point-of-care ultrasonography at Teesside University in the United Kingdom. She's one of the pioneers in POCUS, or point-of-care ultrasound, education in Dubai, and a director of point-of-care emergency ultrasound courses held on a regular basis in Dubai and Northern Emirates. Laila is also the creator and editor of www.ultrasoundem.com.
It's a pleasure to be here, Anzal. Thank you for having me.
Thank you for being here and for agreeing to be a part of our talk today. It's worth mentioning that this kind of feels like we've come full circle. I remember my very first RSI, or rapid sequence intubation, was during an arrest as a first-year resident on a shift with you as my attending. Fortunately, I saved some face when I managed to get that ET tube in amongst all of that chaos and crazy environment. Though if you asked me at the time, I couldn't possibly tell you I had the slightest idea what I was doing or what was going on. Feels good to come back after all these years towards the end of my training and have you join me to talk about, as luck would have it, resuscitation.
I must say, Anzal, you were one of the most enthusiastic R1s we had at Mafraq Hospital.
It feels good to just hear the word R1 again. I feel nostalgic and wish I could be an R1 again, but alas, we are where we are. And without further ado, let's dive right in. We'll start with that oh-so-popular pulse check. We're all aware of this situation. Patient collapses, and we're supposed to check for responsiveness and the pulse, usually at the carotid area. I'm getting flashbacks to my life support courses just thinking about it. And the inevitable activate the emergency response system line has to be said. And you can see the scenario playing out in my head and your head. We do this every few years, anyways. But before we go down that road, we all have to visit, every few years for certification. Let's talk about that pulse check. The two fingers, colloquially referred to as the digitometer, to measure the presence or absence of a pulsation in the neck. Is it really as reliable as we might think?
Manual pulse checks. Who's still doing that? Well, the current standard of practice mandates us to doing manual pulse checks. Can we do better than that? So back in 1996, in a study by Eberle, and I'm sorry if I'm mispronouncing the name of the author, but he used first responders. They were asked to check pulse on bypass patients. And imagine out of these, 10% missed absent pulse. 45% missed presence of a pulse, despite the blood pressure being above 80. Out of 200 participants in whole, only 15% had accurate diagnosis in less than 10 seconds. And out of these, only 2 identified pulselessness correctly within 10 seconds. In another study where emergency medicine ICU physicians and nurses were included, only 43% were able to detect the pulse in less than 5 seconds. And finally, there was a study on a simulator where BLS providers were shown to give an accurate diagnosis in less than 40% within 10 seconds.
Yikes. So basically what you're saying is, even if we're being a bit generous, this is like 40-50%. This is almost like flipping a coin. That potentially means a lot of time spent figuring out if the pulse is there or not, and you're just prolonging that hands-off compression pause. You talked about 10 seconds being that golden time. That's what we're taught, of course. So not so brilliant if we're not meeting that mark. Can we do something to perhaps make this easier?
Yes. While you're welcome to use your digitometer however you like, keep in mind that sometimes it's unreliable. One way to augment your diagnostic accuracy is by using POCUS. So studies have shown that when you compare POCUS to manual palpation, the use of Doppler ultrasound did not take longer full pulse checks, but was associated with a more accurate diagnosis for underlying pulse. In another study by Bedra in 2019, which was an RCT on over 100 patients, ultrasound had improved the first pass success with Doppler compared to manual method, which was 99 versus 89%.
That's interesting. So, I mean, from what I know, you can basically, how you do this is you use a linear ultrasound probe and just stick that onto wherever region you want to assess the artery for flow, much like when you're doing a central line. For example, if you're going for the carotids, you place it on the lateral aspect of the neck and check for pulsation in the carotid artery. And I would imagine visualizing these pulsations would be good enough to constitute a femoral or positive pulse.
So not only that, you can also, if you have a doubt, you can just compress the vessel. And if the carotid compresses along with the jugular vein, that means that carotid does not have enough flow, or that would be equivalent to an absent pulse.
So where do you usually place your probe in these situations?
I personally prefer to go for the femoral artery. The reason is that you're more away from the chest compressions and there's less happening at the femoral artery as compared to carotid artery, where there's intubation going on. There's usually more hands, there's RT, there's suctioning going on. So femoral artery is more accessible. Now, one drawback to this is that you need an extra pair of hands that would hold the probe throughout the resuscitation to check every time the presence of pulse. And this would be a good utilization if you have somebody like an intern or a medical student.
I would imagine that makes a lot more sense, actually. So you wouldn't want to distract yourself from the rest of the resuscitation techniques and algorithm that's happening. So I guess, yeah, this is one for the students and interns to possibly stand by. And femoral seems actually more preferable now that I think about it. My instinct was always to go back to the carotids because that's where we do our manual pulse check. But I think perhaps in future, the femoral area is something to consider. All right, let's move on. So, on to matters closer to the heart, so to speak. When a patient is unresponsive with no pulse under care of a healthcare professional, they will usually have access to a cardiac monitor to which they will be hooked up, and the electrical rhythm is then assessed. As we learn in our ACLS protocols, we are supposed to determine if this is a shockable rhythm, is it asystole, or is it a pulseless electrical activity, aka PEA. Oftentimes, the rhythm is clear and we can begin our algorithm as needed and as directed. But sometimes you see this vaguely oscillating, dull, almost flat, but not so flat line on the screen, and you're like, what the heck? Is this a fibrillating heart? Is this asystole? Is it inconsequential waves? Is it artifact? What's the gain on this thing? And you're just sort of left in the dark there. Enter the mighty echocardiograph, and you can get a real-time answer to that question. One look at the heart, and boom. You can see the rapid beating or vibrating heart in many ways. That would be a fine VF, something that doesn't look like VF substantially on the screen, but looks like a VF when you look at it through the ultrasound. And then you go shock the guy. If there's no motion detected, then there you have it. You have a confirmed answer. This is indeed an asystole with no cardiac motion. This is also known as a cardiac standstill. Therefore, you can use this nifty gadget, POCUS, to potentially gauge the need for defibrillation versus no defibrillation. And that's all well and good. But I've been reading up around echocardiography and arrest, and I found that while we all know that no pulse with electrical rhythm is equal to PEA, we sometimes have what's called a pseudo-PEA, and I've been hearing a lot of this in literature nowadays. Dr. Laila, just what in the heck is a pseudo-PEA?
That's a very good question, Anzal, because we've all been there in situations where we're staring at the screen and we're not sure, is that really an organized rhythm? Is it a fine VF? And then is it a PEA because we cannot feel the pulse, or are we just bad at feeling the pulse? So the important terms to understand are what's a PEA and pseudo-PEA. So basically, both PEA and pseudo-PEA show an electrical activity on the monitor, but there's an absent palpable pulse. But in a pseudo-PEA, when you look at the heart with the ultrasound, the heart is in fact having some contractility. That means there is a cardiac output, but it's too low to be detected by manual palpation. So that's not really an electrical dissociation. Whereas in a true PEA, there is electrical activity on the monitor, but when you look at the heart is completely doing nothing. Another term you want to be familiar with is the cardiac standstill. So a cardiac standstill is a sonographic finding where, again, the atrium and the ventricles are not contracting. There you might see some valvular movement. However, there's no contractility of the ventricles and atria. Now, if that is associated with an asystole, that would be a cardiac standstill seen with asystole. And if there is a rhythm on the monitor, that would be, again, a true PEA. Does that make sense?
Yeah, that kind of makes sense. I'm sort of imagining this in my head as a low battery, no battery situation. So something with the electrical activity but some motion means it's too low for us to see it as a pulse or a perfusing rhythm, but a no battery means you really got to restart that heart. That means the standstill. I don't know if that makes any more sense or less sense. I'm not sure.
Yes, exactly. So basically a pseudo-PEA would be a profound state of shock.
Mm-hmm. So I guess you could probably say that that's better news than absolutely nothing. So,
Yeah.
Okay. That's interesting.
Alternative terms used, which a concept which was introduced by Scott Weingart from ECREM was PREM and PRESS. So PRESS stands for pulseless with a rhythm with echocardiographic standstill, which means true PEA. PREM stands for pulseless with a rhythm with echocardiographic motion, which is the pseudo-PEA.
That's a mouthful. I think I'm going to stick to pseudo-PEA and true PEA.
Yeah, me too.
Just because it's a lot catchier when we say it. So looks like ultrasound is on the up and up. What's interesting to note is that the ultrasound or POCUS can also make things easier when managing the pulseless electrical activity or PEA. When dealing with PEA, we are taught that we evaluate for the cause and run through our H's and T's and try to find the reversible causes. But sometimes in the madness that is the resuscitation area, it's quite a reach for you to recall all 10 things on that list. I mean, I'd be hard-pressed to recite all 10 of them right now. What I found particularly useful is using the ultrasound to sort of gauge and get my mechanical causes of arrests out of the way, literally by visualizing the presence or absence of signs using the echo probe. I mean, these are the real killers that you want to be able to pick up on and reverse as soon as possible. So during an arrest, I could look at the area around the heart and immediately identify if there's a tamponade from an effusion, RV dilation, or even an embolism in transit. Things like pneumo or hemothorax can then readily be identified, and interventions can rapidly reverse these causes of pressure on the myocardium. This effectively becomes a much more systematic way of stratifying actionable problem areas as you run your resuscitation. Interestingly, this sort of brings into account a paper from 2017 by Gardner and his team called, which basically implemented what's known as the Cardiac Arrest Sonographic Assessment Protocol, or as they call it, the CASA protocol. My temptation to use my limited Spanish here is I'm going to try to suppress that. So they minimize pauses in this paper by focusing only on 3 major killers to look for with your probe. Firstly, you look for tamponade. If it's present, perform pericardiocentesis as needed. Step 2, you look for signs of PE, pulmonary embolism. In this paper, they mention RV strain, but you could very well see an embolus in transit in some patients. So whatever signs are indicative of PE would be what you're looking for in this step. Step 3 is assessing the cardiac activity, which we kind of outlined earlier, whether the patient has motion or is in true standstill. Because standstill ultimately is associated with a very poor prognosis in arrest patients, this segment being towards the end kind of makes sense because it acts more to prognosticate chances of revival, as well as identify fine VF, as we mentioned earlier. Some ancillary steps are also then described to look for pneumo and hemothorax, and perhaps extend with a conventional fast scan, look at the aorta for AAA. But essentially, what you're looking at with this protocol is a more simplified way of looking at the heart, what's causing pressure on the heart, can we change that course and bring this patient back from it?
I agree with you, Anzal. I think CASA is a really nice protocol because it's easy to remember. I mean, there have been a number of protocols published out there, such as FEAL, the modified FEAR, CAUSE, rapid cardiac ultrasound. So there are many to choose from, but CASA is easy and simple. And it has also been validated. So in a study where they applied CASA on trainees, they found out that they can reduce the pulse checks from 19 seconds to 15 seconds when they've applied the protocol correctly. Unfortunately, though, Anzal, oftentimes identification of mechanical cause also means that patient would have worse prognosis. Many mechanical causes of arrest, despite the interventions, end up with a worse survival to hospital discharge. And we've seen this in the recent study published by Jung in 2020. And I'm sorry again if I'm mispronouncing the name of the author here. But he has found that compared to the patients who had no mechanical cause of arrest, those with mechanical cause of arrest did much worse. Now, these were all patients with out-of-hospital cardiac arrest. However, early detection of reversible causes can still play an important role in turning things around for many patients. Now, Anzal, we've talked a lot today about how we can utilize ultrasound in cardiac resuscitation to help us guide the CPR. But there are other tools that are available bedside that we can utilize, and they can provide us with more information about our CPR and about what's going on with the patient. For instance, use of arterial lines during CPR can help predict whether a patient has regained ROSC. So if you see a diastolic blood pressure above 30 or 40, that means the patient has a perfusing rhythm. Oxygen saturation waveforms have also been used. And if you see a persistent waveform, that again means that the patient possibly achieved ROSC. And finally, end-tidal CO2 can be used to monitor the quality of chest compressions. And also, if you see a persistent elevation above 30, that again means that the patient probably has resumed ROSC.
That's interesting, yeah. So basically what you're doing is uncovering hidden causes or hidden signs and symptoms of better prognosis or return of spontaneous circulation by using these adjuncts. Am I correct?
Definitely. And there's more to come in the near future. ECMO CPR is an exciting new modality in resuscitation, and it forms a bridge for patients in shockable rhythm to reach the cardiac cath lab.
All right. That brings us to the end of our first episode on some outlier concepts in cardiac arrest care. We discussed today the concept of the POCUS pulse check, noting that we could reliably identify pulses better using an ultrasound probe with visualization of the arteries compared to manual palpation. And this does not have to increase the amount of time taken to find that pulse in the unresponsive patient. We also talked about echocardiography in arrest and how we can use ultrasound visualization of the heart to rapidly identify mechanical causes for arrest, whilst also confirming any vague rhythms on the cardiac monitor by assessing the movement of the heart, or lack thereof, in real time. All in all, it was an absolute pleasure to talk about these concepts in resuscitation with you, Dr. Laila. Once again, thank you very much for joining us and contributing to our humble little podcast, ECREM Talks.
Thank you, Anzal, for giving us the opportunity to discuss it. I believe it is time we start doing things differently. Why would you choose to continue practicing resuscitation blindly if you have a tool that allows you to see what is happening within the heart?
I agree entirely. A lot of these tools have an emphasis on the fact that this is all real-time information, real-time actionable knowledge that can potentially guide or divert your management tactics while you're practicing on this high-risk individual who's in your emergency department. So, with that being said, it was a pleasure again, Dr. Laila. That about ends this episode of ECREM Talks. Join us next time when we discuss refractory VF and some exciting new prospects in cardiac arrest care. Until then, this is ECREM Talks signing off.